Good morning, everybody, and welcome to this session on aortic stenosis, lessons from the heart team on TAVR, SAVR, HALT, and beyond. This is a joint session with TCT. I'm John Mamarian. My co-moderator is Jonathan Leipzig, and welcome.
Some updated news. I don't know.
Okay, yeah, go ahead.
Unfortunately, I received an email sometime in the middle of the night, and I'm not sure if the organizers had notified you, Dr. Mamarian, but Maria Nick-Clavel, her flight was canceled from Quebec City yesterday, and owing to weather, and so she can't get in. She did send me some slides, but they were frankly so elaborate in their depth of hemodynamics and echocardiography that I didn't even begin to consider presenting them. Fortunately, we have real luminaries in the field of structural heart disease and coronary disease with Professor Waxman, who obviously needs no introduction, has really led the field, and not only of coronary intervention, but with some of the seminal work, especially recently, in the low-risk population, having published a randomized trial well before even the two randomized trials this year. So this is going to be a great opportunity. And our first presentation is it Dr. Waxman?
Yes.
Oh, okay. And the title is? Sorry.
Okay, so Dr. Waxman, the first speaker, and the title is, What do imagers need to know about TAVR?
Well, thank you very much for the opportunity. It's an honor to be here. I actually was asked to present two talks initially that they were on the program. Just have to see how we do this. Yeah. So the first was about when is SAVR better than TAVR, or the second one was what the TAVR issues that needs to be known to the imager. So TAVR is now approved therapy for high and intermediate risk patients. It is in the guidelines and then has been established based on randomized clinical data and low-risk studies supporting labeling expansion, and that's probably going to come soon, I believe, in the fall. What TAVR did is really establish the heart team, which is including interventional cardiologists, cardiac thoracic surgeons, imagers, and support staff. And it relies on TAVR-specific risk assessment, which is grounded in preoperative imaging. Now, we can do general anesthesia, we can do conscious sedation. We use CT for all the TAVR assessment, and TEE versus TTE guidance based on risk. And also, there is a meticulous attention to the vascular access and closure. So imaging has been an important part of planning during the procedure and post-procedure. We actually depending, it's really an integral part of TAVR today. This is the TAVR heart team. You can see it's involved many disciplines, and it really works very nicely with this collaboration. I think it did change the entire atmosphere within the cardiac thoracic surgery, intervention. We have valve cardiologists, structural interventionalists, anesthesiologists, consultants, dedicated coordinating, and obviously imaging experts that assist us in the procedure. What are we looking is for the patients, and again, we did realize that there is a lot of data that has been done so far in the arena. And this is since 2007. In the US alone, there are more than 15,000 patients that have been enrolled in FDA studies. 10 of those are randomized clinical trials with multiple generations of 4 different TAVR systems. And these studies are continued to evolve and ongoing, and they are the ones that dictated the guidelines. So you can see the evolution and the state of the TAVR from 2011, when we started with Partner 1A, which was extreme risk, all the way to now Partner 3, Evolut low risk, that are going to grant us the expansion of labeling for the low-risk population. This definitely affected the volume, and as you can see here, TAVR is exceeding SAVR by a lot. So the deflection point was around 2015. In 2018, based on the TVT registry and the STS registry, there are about 58,000 TAVR procedure per year versus only 25,000 SAVR, and those numbers are going to continue to diverge as we get the low risk. The estimated of US TAVR growth you can see here at 2025, and this is number of cases by thousand. So if today we are doing about 67,000 in 2019, the estimation that within 6 years, this number will go to 164,000 of TAVR per year. And the number of TAVR across all the aortic valve replacement would be 76% in 2025. It's not that far, it's only 5 years from now. We identify different risk stratification from the extreme, which is the small bubble here, all the way to the low risk, which is actually the largest population that requires to have replacement. Now I'm going to go quickly through how imaging is really important for us, because we do have different access today. From the traditional transfemoral, we're going all the way to carotid, direct aortic, iliac aortic conduits, transcaval, transapical, and all of these are based on what we get from the imaging. So many of you have been seeing those images, but they are very critical because they are determining which site are we going to use, how much calcification we have in the vessel, what is exactly the vessel size. So this CTA vascular assessment is really critical for us, as well as determining what valve size are we going to use, how much eccentric and elliptical is the annulus, how much of this is calcified, and how much is involving LVOT calcification. Now, during the procedure, we started with TE, but now we're using more TTE, except for very specific questions. And here is a case with no significant PVL, which is what we want to hear before we take the patient off the table. But sometimes we do see moderate PVL, and again, the echocardiographer in the room will tell us, you're not done yet, because we know that PVL can be associated with grave outcomes. So we do post-dilatation, and then we're getting only trace PVL that is acceptable, and then we are happy with the procedure and we can move on. Now again, there is a lot of things going on in the arena of imaging, and you're going to hear it through this session, so I'm not going to dwell on that because that's not my expertise. I'm using this service happily and trying to learning every day, but I think that we're always learning from our imaging team in the center, and it is really critical because if you don't see this LVOT calcification, and you're going to find it during post-dilatation, you may get some annular rupture, which could be devastating. So all those are very, very important. Also determining what is the size. So many of the complications can be avoided just by getting the right dimensions, and this is why imaging is so critical for this technology. Now let's go to the data. We actually have, as I said, studies across all the risk from extreme, high, intermediate, and low risk. All those trials have been published in the New England Journal of Medicine. All of them has been randomized clinical trials. So we have really very support data on the 1-year results. But we also have 5 years outcome from partner 1, which was the first study. And we have also studies now going all the way up to 10 years follow-up, although most of those patients, because of their age, they didn't last that long. So if you look on the extreme risk, just to compare and contrast, medical therapy is not doing well. You have to do TAVR for any patient who is extreme risk. And you can see here the reduction in all-cause mortality. And if you look at high risk, now we're comparing to surgery. And as Mike Mack said, if we are equal to surgery, that's a win for TAVR because it's less invasive. And you can see here that all-cause mortality for the high-risk population is about the same thing. And we're getting very good hemodynamics when we're looking on the aortic valve mean gradient and also the AVA after the procedure. Core valve, which is the self-expanding valve, showed similar results for the high risk. Again, the 1 and 2 years follow-up did show that actually there are slightly superiority or a trend for superiority when you compare it for the high-risk population versus the surgical approach. So that has became a default therapy. Now for every high risk and extreme risk, we are definitely going with TAVR, and even the surgeons in agreement to that. Also, there is an edge of superiority with respect to the hemodynamics because we're using larger valves because we based on CT. We try to educate our surgeons, why don't you do CT for every patient that you are doing SAVR, because you may find that you need to get much larger valves that you're putting together. They are kind of pushing back on that, but I think giving our results, they have to pay attention also to the imaging. Now we're going to the moderate and the low risk. So the moderate risk, there were actually 2 studies. This definition is the STS score 3 to 8% for high risk for mortality. Mean age is still 80 on those intermediate risk. Again, there was 2 studies, part in 2A and S3I trials. They have been both published, one in the New England, one in the Lancet, and they showed again that there was no inferiority when you take the intermediate risk comparing SAVR versus TAVR, which again, it's a win for TAVR. And that was true for also the S3. So when you ask yourself at the end of the day, surgery is better, maybe less vascular complication and maybe less PVR, but if you look on TAVR, better mortality, better strokes, less AKI, less severe bleeding, less new onset of atrial fibrillation, better valve area, better 30 days quality of life, better 30 days 6-minute walk, less ICU and hospital length of stay. So if you do all these, I mean, which therapy do you think is better? I mean, it's clear, and I think even the surgeons are starting to admit into that. If we look at the Strata self-expanding for intermediate risk, a study that again showed all-cause mortality, there was no difference between SAVR and TAVR for the all-cause mortality, but as I said, there were other differences. So let's go to the low risk. Now we're dealing with the bread and butter of surgery. Less than 3% STS, mean age of those guys are between 65 to 80. And initially there was a study that was done in Europe called the NOTION study, and that study showed at 5 years that there was no difference in the all-cause mortality between surgery and between TAVR for the low-risk patients. But when you look on the hemodynamics, again, the hemodynamics over 5 years were better for the TAVR versus the surgery. The 2 pivotal trials in the US use the self-expanding, which was the Evolut low-risk trial, and the balloon expandable, which is the S3 in the Porter 3 trial. We had actually our own study which preceded these studies in the Methodist Washington Hospital Center. It was actually a multi-center trial, non-randomized, 200 patients. We call it the LRT study. So we put all those trials together, and we're looking, there were some differences because our study was just a registry, but the pivotal trials were randomized trials, 1-to-1 to SAVR. You can see the number of patients was different, but what's unique about those patients is that they really have a very low STS score. Ours was 1.7, Partner 3 was 1.9, Evolut low risk was 1.9. The mean age is getting lower. We're talking about now not the 80s and the 90s, these are 73, so early 70s. Some of them had prior CABG, all of them transfemoral approach, and right now none of them was enrolling into the bicuspid. Our trial, which was the first to present last year in Munich, exactly last year, did show 0 mortality at 30 days and 0 disabling stroke at 30 days. I know there is a 0 chance that this will be replicated, but it was close for the other trials. If we look on the other trials, we have seen similar results in the Porter 3 trials. You can see here 1-to-1 randomization that most of those cases got constant sedation. When they got TAVR, the procedure time was 58 minutes versus 208 minutes by surgery. And obviously the median ICU stay 2 days versus 3 days. Total length of stay 3 days versus 7 days. Discharge to home, 96% of the patients with the TAVR versus 73.1% with the surgery. And concomitant procedures were done 7.9% in TAVR versus 26.4% for surgery. So if we look at the in-hospital death, it was 0.4% in TAVR versus surgery 0.9%. There was only 2 deaths. So the results of the surgery are excellent, but our results are also as good as the surgeon. There was 1 complication of annular rupture in the TAVR, and there was some one patient with coronary obstruction and one with ventricular perforation. But overall, when you look at the primary endpoint of the study, so surgery had at 12 months 15.1%, TAVR was 8.5%, and this is at 12 months, obviously met the non-inferiority, but it also met the superiority, which was not intended, which means that TAVR for low risk is superior than SAVR. This is the all-cause mortality. Just the all-cause mortality is 0.09. This is all stroke, less stroke with TAVR, statistically significant, 0.04. Death and disabling stroke, also statistically significant for TAVR versus SAVR. And rehospitalization, which was part of the component of the primary endpoint, was also lower in TAVR versus the SAVR. This is true for all the subgroups for any age. All of them are in favor of the TAVR when you compare against the SAVR. And these are some pre-specified secondary endpoint. And I would point out, if you look on new onset atrial fibrillation, 5% with TAVR versus 39.5% with SAVR. And we know how bad it is, atrial fibrillation. So strokes, 0.6% versus 2.4%. And also pacemaker rate, there were not much differences between the SAVR and the TAVR. Obviously, this was also published in the New England Journal of Medicine, and this was also presented at the same session at the ACC 2019 with the lower risk with a self-expanding valve, which was a similar design, except that they're going all the way to 2 years, and they have adaptive trial design with Bayesian approach. So they were looking on primary endpoint, which was also met for non-inferiority, looking on all-cause mortality, disabling stroke at 2 years, but they presented just the 1 year data, which was showing that the non-inferiority was met in that study, and that was an important. If you look specifically on the Kaplan-Meier curves at 1 year, this was not statistically significant, but it's very close. It's 2.7 versus 4.6 with a p-value of 0.065. Probably in 2 years it may be statistically significant, and the stroke rate are statistically significant lower with TAVR compared to SAVR. Rehospitalization is lower as well. So we are looking on this, and we are seeing there are some durability issues that we have to be worried about. We still need to learn it, and how are we going to assess it? Only with imaging right now. So we have developed a whole new criteria for echo and CT determination. These are the things that we have to be cautious about, and they're going to be, again, visualized by imaging. What can be, whether it's a PANOS or HALT or any of these that you'll hear for the remaining of this session. Well, one thing we cannot ignore, and this is the mortality with the low risk. You see at the end the LRT, our study, the partner tree, and the low risk TAVR of the core valve, with a very low risk mortality compared to how we started with the Partner 1A with 30%. This is a 1 year mortality. So clearly a very important landmark. And at the ACC 2019, Eugene Brandwald was asked to comment on that, and he said, this is a historic moment, and all of us here should remember it as such. It was a very emotional moment, and it was very comforting to see Eugene Brandwald coming to the microphone and stating this statement. Now, again, this study devices are developing. We have new devices that are coming, continued iteration, so our results are only going to be better. But I think this technology started to get matured, and we're seeing, again, new self-expanding, new supraannular valves. Again, a lot to be developed through this exciting field. So what is next? I think we are going to get the low-risk patients. We are looking also on low-flow, low-gradient AS, patients who are going to have concomitant disease, CAD, mitral regurgitation, atrial fibrillation. Can we do ablation and putting Watchman and putting the valve in the same setup? There's a question about reimbursement, but other countries maybe it's applicable. And also we are thinking about looking into devices that are going to take care of high risk aortic regurgitation, because these are not there yet and they are not addressed by the current system. So the next talk that I was supposed to give to replace one of our surgeons who couldn't come today was what is the, let's put it this way, when SAVR is going to be better than TAVR. And this is the international interventional cardiology view. It's always going to be TAVR better than SAVR. And this is actually a slide from Lars Svensson, who came to CRT 2019 and says, well, you know, if we continue like that, we would operate for food. I don't think that's going to be the case, because I give you, even though you're seeing here, and again, what's happening right now, that the surgeons are just operating on low risk. So if the low risk are going to move to TAVR, he may be right. However, there are some scenarios that may require SAVR, and I think they would maintain this 20-25% SAVR. So some of them are patients for high risk of PVR that have calcium in the LVOT or potentially for root rupture. So those cases, I think, would be maintained with surgery. We have an issue to deal with LVOT and very heavy calcified valve. Bicuspid valve and low risk with and without enlarged aortic root maybe still be better with surgery. And large root requiring the replacement definitely will go with surgery. We're not going to do that. Very young patients who want or need mechanical valves will be done by surgery. When you have aortic annulus area greater than 750, we just don't have the valve sizes for that. And predominantly AI and very little AS, those patients do not do well with the current valves that we have, maybe in the future. Short annulus to the STJ and worried about root rupture, and also worried about low coronaries and potentially coronary obstruction that cannot be managed by basilica and other methods, would be favoring the surgery. So what do we need is really to work together as a heart team and to determine what is good for the patient. What are the things that we still worried? We worried still about access to coronaries in the young patients. We worried about the durability, but we don't have good durability also on the new surgical valve, and that will come only with time. And I think we also have to be educating and getting acceptance of the surgical team that they are part of this decision and they are also part of this procedure to help us to move to something which would be less invasive. So I would say that these are when SAVR is better than TAVR. I mentioned them. And I'll give you one last scenario to end here. What do you do with a patient less than 6 years old? So today, he's definitely going to SAVR. Maybe 10, 15 years after, he's going to have valve-in-valve. And after that, I'm not sure, maybe another valve-in-valve. But remember, when you do two valves-in-valves, you're basically obstructing the access to coronaries. And those guys at the age of 80 may need some coronary intervention. So to be provocative, maybe we'll change the sequence and we'll take the young 60 years old. If he's doomed to get anyway bioprosthetic valve, we'll give him a TAVR. Then if he has to replace the TAVR in 15 years later, he will get a SAVR, and that will take another 10 years. And then if he needs another one, then he'll have valve-in-valve also through a TAVR. So that's kind of an interesting, provocative scenario to start actually early on with the TAVR and not with the SAVR. Although what I would tell you that in most of the institutions, the threshold of the age has been dropped to the mid-60s now, and some of those are early 60s to have bioprosthetic valve. And if that's the case, then we may advocate that TAVR would be better than SAVR because you get a better hemodynamics, so it's something to consider. So TAVR, valve-in-valve, SAVR, valve-in-valve, a lot of things to think about it. But I think one thing is for sure, the technology is matured. And again, I'd like to invite all of you to come to CRT 2020, which will be at the Gaylord. We have one day on a Sunday, which is just on imaging for structural heart, including CT and echo and all of the above. So thank you for the opportunity to be here. I'd be happy to.
We'll take questions at the end. Really an exceptional overview, and for those of you who have not attended CRT, I would highly recommend it, not just for the structural, but really an incredible overview on coronary disease, atherosclerosis, and beyond. Ron gets the truly best in the world to come, so thank you for honoring us and joining us at this meeting. So I've been charged with, in 10 minutes, doing an update on imaging for TAVR. This seems kind of crazy on multiple levels. One, because there's so many expert people like Dr. Lesser and others in the room that obviously know how to image for TAVR. And two, 10 minutes is not enough to give an overview on all of anything. So what I tried to do is just to select a couple of areas about, I think, the continued relevance of driving the field of CT for TAVR forward. What we saw from Dr. Waxman is the incredible outcomes that we're seeing in these large randomized trials. And I think that there's three things that can be credited for those improvements. One, obviously, first and foremost, is the refinement of the procedural skills of the interventionalist doing it. You know, if an interventionalist has more experience, she's going to do better with the procedure. The evolution of the devices are frankly better than they were in 2007 and 2008, and there's a wider range of sizes. But I think we in the field of CT can take a lot of pride that we've helped better identify patients that are at risk for complications from TAVR. And I would argue that now that we're moving into a low-risk population, many will say, well, you know, do we really need to focus as greatly on the CT? I think we actually need to focus more. You know, the risk of annular rupture in 2007, if I went to John Webb and said, you know, there's some risk of annular rupture, and he'd say, well, Jonathan, the patient is dying of AS and has no surgical options, so I'll take my chances. You can't have an annular rupture if the patient has no mortality risk with surgery. So let's move forward. Core lab work, no personal compensation. I do provide advice to Circle Cardiovascular Imaging, for which I do derive modest honoraria. So I think what we heard, and this is clearly redundant and expressed so eloquently by Ron, that the treatment of valvular disease has been disrupted by the advent of transcatheter interventions. We saw these data just now, and very much supported by all those innovations and advancements. We saw that not only was there equipoise between TAVR and SAVR, but actually there was superiority when it came to a combined endpoint in one trial, and equipoise when it came to the major complications in the other trial. So no doubt that TAVR is here to stay. But I would highlight some of this important work that was done by our lab and led by Philip Blanca, who you'll hear from in a moment, is that it's not that all comers underwent TAVR, at least in this trial with the balloon expandable device. Every week there's a case review call, and every week Philip was on that call, and every week there was a discussion about the patient-specific anatomy. So there's a significant number of patients that were screened out due to adverse root features. And so what I firmly believe is that the surgical risk score is entirely irrelevant, almost entirely irrelevant as to the determination as whether or not a patient should undergo SAVR or TAVR. I think what is really key is going to be the patient-specific risk defined by anatomy from CT. The CT will define which patients, as we heard from Ron, based on root geometry, based on subannular calcium, based on coronary risk occlusion risk, whether the aorta is dilated. All of these factors are going to be determined by CT, and at which point the patient will then be treated either surgically or in the overwhelming majority of cases with TAVR. So what are the outstanding challenges? One is that we continue to move forward around annular sizing. I think that we helped move the field forward a lot by introducing the very concept of the non-circular annulus, as shown to us by Nico Piazzi 11 years ago in Circ Intervention, and really highlighting that CT allows us to recreate this virtual basal ring that is very much the landing zone of the device. And that helped us a lot, because when I look back to the early days when I arrived at St. Paul's in 2008, John Webb used 2D echo. Before that, he gave a woman a small valve and a man a big valve. So, you know, this was a real leap forward. But it is probably, and almost undoubtedly, an oversimplification of the very drivers of procedural success. You know, we focus on this concept of oversizing, putting in a valve larger than the annulus itself to prevent paravalvular regurgitation, but not too large. But if you talk to the engineers, they'll say that's such a physician-focused way of looking at it. Because how did we define the sizing algorithms? What we did was we looked at those patients that had complications and looked at what their sizing was. And what we realized is that if you undersized a balloon expandable valve, you put in a valve smaller than the annulus, 20% had moderate paravalvular regurgitation. So of course, doctor mentality is bad is what we have to avoid, so we're going to do this.
but we ignored for a decade the 80% of patients that were undersized that did not leak. And of course, the engineering mentality is we need to learn about why 4 out of 5 patients were undersized and did not leak. And I think the drivers behind that relate to the very complexity of what is determining device sealing and device capturing. And that goes well beyond our historical approach of simply annular geometry. I don't have any answers for you on that, but I think that's something that we collectively can look at, as we saw from Dr. Waxman with these new devices, better understanding these things. The SCCT put out guidelines this year, led by Philip, and really highlighted, I think, our recommendations for sizing. And I think this is important to understand. If you're using CT, you need to do it in a consistent way. We advocate for whole heart cardiac cycle imaging, sizing in systole, understanding the impact of diastole, using area for the balloon expandable device, perimeter for self-expanding devices, because perimeters will generally drive you to a larger device selection, because we know the annulus is non-circular, and the perimeter of a non-circular structure is always larger than a perimeter of a circular structure of the same area. So that is why we use area for balloon expandable, not because it's better, but because it's a more conservative measure, and it allows you to put on the brakes and tell Dr. Waxman, you know, in this case, there's some risk. What do you think? How should we go larger? Should we not? The other thing we need to do is, again, iterate our sizing algorithms for new devices. And we can't simply assume that a self-expanding device and another self-expanding device needs the same sizing algorithm. This is a self-expanding device called the Centera. These are data presented by Professor Rindeker, looking at the European arm, 150 patients. And this self-expanding device has different radial force, different waist, different sealing with a flare below, in the same way you size differently for an Evolute R than you did for a CoreValve Classic. So we, though, as imagers, need to help our interventionalists continue to understand, based on large data sets, how to size these devices and how to help improve downstream clinical outcomes for our patients. We also need to focus, of course, on the ancillary measurements, and there are many of them, but I'm going to just drive home a couple of points around valve and valve. You know, valve and valve, the field of valve and valve was really, really a lot of what we know, I should say, was brought to us by Danny DeVere, who worked with Dr. Waxman at the MedStar, and then came to us in Vancouver, and Ron Karnofsky, who's also speaking later on in the day from Tel Aviv. And what they taught us is there are a lot of complications from valve and valve. One is gradients. The gradients, I think, are a problem due to constriction. And obviously, a superannular device, such as an Evolute R, offers some benefit that the device is less constrained. The other thing that has helped is the interventionalists have gotten a lot better about higher deployment. Where we can play a role is using CT. And there's an important understanding around using CT around coronary occlusion. And in the early days of valve and valve, there was a poor understanding of the mechanism of occlusion. And we were measuring from the annular plane to the coronary ostia. Of course, in the setting of valve and valve, the height of the coronary artery is only a modest predictor of risk. Clearly, if the coronary artery is above the surgical valve, then there's no risk of occlusion. But what's really driving the risk of occlusion here is the fact that we're creating a covered stent in the root of the aorta. We're putting in a transcatheter valve, or fortunately I'm not, but an interventionalist is, and creating a covered stent in the root of the aorta. And if that surgical valve is canted towards the coronary, or if the sinuses are not capacious enough, the risk of mechanical obstruction is elevated. And some people said, well, why don't you just measure the sinus of Valsalva? The issue with that is that the sinus of Valsalva is only a modest predictor of risk because it ignores the surgical tilting. So if the valve is tilted towards a coronary ostia, despite a capacious sinus, that covered stent may very well tamponade the left main coronary artery. So we proposed a number of years ago this fairly basic process of simply doing a virtual implantation, sized on the basis of the information provided for the surgical valve, although we're learning more and more in the setting of unknown surgical valve size, how to use CT to actually define the surgical valve size. But assuming we know what it is, we deploy a ring of comparable size to what is intended to be deployed, and then we measure the distance between the virtual ring to the coronary ostia. A large registry was published in European Heart Journal, and what they showed us, Enrique Ribeiro put it together, and we analyzed 150 CTs without coronary occlusion, and I think it was somewhere around 27 with coronary occlusion, and using a VTC of 4 millimeters was strongly predictive of risk of coronary occlusion. So you may say that seems fairly easy, and we're comfortable doing that, but the field of interventional cardiology is always wanting to innovate and always wanting to push the envelope, so to speak, and treat more patients. And because of that desire to be more effective and offer treatment and therapy to more patients, we need to meet the needs of our interventional colleagues by understanding the imaging requirements. So there's a procedure called Basilica, very similar to Lampoon, being led by the NIH and the Washington Hospital Center and many others. And this idea is that patients who may have mechanical obstruction, that perhaps the interventionist can alleviate that obstruction by putting a catheter and a cautery device and linking, and then thereby slicing either the native aortic valve or the surgical valve. And so what we can see here is a potential Basilica procedure with a SAPIEN device and then a core valve, and the opportunities of actually opening up diastolic flow to the coronaries by performing this Basilica procedure. So there's a paper in press, Danny DeVere led it with a Japanese colleague, and what it really highlights is the opportunities, albeit the very early days of the role of CT, but maybe CT can help us, because some patients, even if you do a Basilica, if the alignment of the posts is not respectful of the coronary ostia, you can slice it all you want, but you're not going to improve the flow. And so the eccentricity of the coronary artery, I think, will be something that we can identify. Finally, in closing, I think there's much more work to be done around bicuspid morphology. I often say that the field of surgical intervention and cardiology has really been pushed forward greatly by the Sievers paper published in 2007. It really has defined our understanding of what is bicuspidity. But I think one of the other limitations we have is that we get a little too intoxicated with data that we see presented, and we take it as mantra. When you think about it, very few things last in the field of medicine more than 10 years. And the Sievers classification, I think, has pushed us forward a lot, but if we don't look beyond it, it has the potential to actually hold us back. So if we assume that Sievers is the 11th commandment, that the only way you can have bicuspid morphology is defined based on the presence of raphe, then I think we're going to miss a significant opportunity to learn about what we feel are a spectrum of bicuspid morphology, variations of bicuspidity that may not allow themselves to be classified by the Sievers classification. So this is from the guidelines, a very nice figure put together about a potential of how we can use CT, not to be definitive. This will also iterate. It'll change in 2 years, 5 years if we're lucky, but we need to continue to look and understand. And the reasons we need to look and understand is not to say you should or you shouldn't do TAVR, but to better classify the patients so we can understand how they do after TAVR, so we can then make a better case as to which patients are actually good or not good candidates for TAVR. So what do we know? We know that patients with Sievers type 1, heavily calcified raphe, are poor candidates for TAVR. They experience more leak, they experience annular rupture depending on the device. This is an example from the intermediate risk trial before they instituted core lab support. The patient was diagnosed at the site with a type 1 heavily calcified bicuspid. They decided to ignore it and underwent TAVR, and they perforated the sinus of Valsalva. This is hostile root anatomy, as we heard from Dr. Waxman earlier. What we have seen is that there's growing confidence with either asymmetric cusp fusion, functional bicuspid, or as Hassan Jalalawi called it, tricommisural bicuspid valves. We see cases like this that we just look at and we say, this doesn't look like a typical valve morphology. There's calcium in between the cusps, suggesting that perhaps the calcium is being deposited in some sort of fibrous bridge that the patient was either born with or developed over time, but presents later in life. Another limitation of our historical bias is that you can't have a congenital abnormality that presents at 82. But of course you can if it's just on a more modest spectrum of disease. In the same way we have some patients that present with aortic dilatation earlier and not. So what do we know from this very elegant paper from Dr. Yoon and Raj Makar, a large registry, is that with newer devices, these patients with so-called tricommisural bicuspid valvular disease do very well as compared to those with tricuspid aortic stenosis. So there's absolutely no reason why Dr. Waxman and his colleagues shouldn't consider these patients good candidates for TAVR. I'm going to close on that the other area that I think in bicuspidity that I would want to highlight that I think you should take some time to attend is Jonathan Weir-McCall has a poster looking at superannular sizing. And that is being presented at this meeting. This very concept that we should consider different sizing algorithms for bicuspid valves has been brought to the fore by a number of interventionalists. And I think his poster will be very important, and we as a field of imagers need to be very careful. Before we start adopting new measures, we need to define whether or not they're reproducible and how they impact on sizing and the potential downstream effect on outcomes. So I would recommend that you pursue his abstract in Learn Pharma, and I really thank you for the opportunity again.
Thanks very much, Jonathan. Our next speaker is Dr. Philip Blank, who's going to talk to us about HALT, tips and tricks on how to grade severity.
Thanks for the invitation and introduction. Okie doke. So I somewhat broadened the topic, and I'm going to talk about CT in the setting of suspected bioprosthetic valve thrombosis. Another disclosure slide. So currently there's a growing body of evidence that leaflet thrombosis occurs after TAVR and after SAVR. Most importantly, this data is derived from research studies where in a systematic fashion or in a registry fashion, every patient in a certain center underwent a postoperative CT. That, of course, does by no means currently imply that patients should undergo CT after TAVR. That's where current data is derived from. Sometimes, however, a CT may be clinically indicated after TAVR, for example, in the setting of an increased gradient. So most important, I think, from a clinical practice point is to have a good post-discharge echo, to have a baseline gradient after TAVR, and then on follow-up, or if the patient becomes symptomatic and there's an increased gradient, there may be a suspicion for thrombus, then I think a CT is clinically indicated. And then, of course, sometimes you perform CTs for other indications, such as mitral imaging prior to a transcatheter mitral valve or mitral valve repair. And for that reason, I think you may come across patients with TAVR in situ where you may observe findings of leaflet thrombosis. CT is challenging in those scenarios because of metal and motion artifacts, and that's something which you have to keep in mind when choosing the appropriate protocol or the CT system to be used. I think what is most important is to cover the entire cardiac cycle, and that's often forgotten about. This gives you redundant data to choose from, also provides you with both systolic and diastolic information, which is important to then also judge the degree of leaflet restriction. You can employ higher tube currents, for example, 140 kVp, which may decrease the amount of beam hardening artifact. And I think the most important aspect is the target heart rate. Those patients at one point had aortic stenosis, and I think in coronary artery imaging, you're used to lower the heart rate to your institutional target heart rate. In patients with aortic stenosis, you will obviously not do that. Otherwise, you're going to end up with high frequency of CPR and code blues. However, those patients that have been treated, they don't have aortic stenosis anymore, and for that reason, you should really think about lowering the heart rate prior performing a post-TAVR CT. And I think the slower, the better, and that's really important for image quality. You should be familiar with the typical appearance. This here is an image which we actually created in 2011 and shows a first-generation sapien valve, which at that time typically had those very pronounced posts where the leaflets were actually attached to, which then, of course, obviously cast artifacts. These are images of a core valve. Typically here is that the leaflets appear thinner than in the sapien valve, sometimes actually very faintly and difficult to visualize. Most importantly, when you're looking at those images is that you want to have a symmetric appearance of all leaflets, and I always compare that with brain imaging on a brain CT. If you don't know whether something is abnormal, you always have a second side, the other side to compare it to. And if the finding is symmetric, it's rarely abnormal or not an acute finding. That is, I think, also what pertains to those valves. Those leaflets should have symmetric appearance, and you see in the upper right-hand image the leaflets are depicted in a very faint but symmetric fashion. Upper images in diastole, nice visualization of the leaflets. In systole, you have more artifacts, obviously, depending on your scanner type and the phase you choose. In this scenario, you can actually see the leaflets in systole opening in a symmetric fashion, almost in line with the stent frame. A second set of images, different patient, different CT scanner. Again, in diastole, you can see the leaflets a little bit more faint. In systole, no images visualized, maybe due to the temporal resolution of the scanner, maybe due to the beam hardening artifacts. And important, when you're looking at artifacts, they are always in line with the direction of data acquisition. So pretty much with the it's perpendicular to the z-axis of the patient. That's important then when interpreting those streaks. Is it leaflet or is it a beam hardening artifact? And leaflets typically have a curvilinear pattern and cross the artifacts. And that's, I think, very, very important for a correct interpretation of these images. Here, a case with leaflet thrombosis. I think it's very easy to identify. 2 out of 3 leaflets demonstrate significant thickening. Upper right-hand image in diastole, you can see how it extends from the base. It's thicker at the base and then thins or peters out towards the tip of the leaflet. And often we refer to that as a meniscal-shaped hypoattenuation or hypoattenuation pattern. In systole, same finding. That leaflet is completely restricted, largely immobile. Different patient, a less pronounced finding. Upper image, again, diastole. You see that there is, on the base of one leaflet, like a little bit of meniscal thickening. And again, this is in keeping with leaflet thrombosis. And in systole, very similar finding. Oh, perfect. Thanks, Jonathan. In systole, again, the same finding here. And most importantly, if you have good image quality, you can actually see that the leaflet starts hinging at the end of the thickening. So even a little bit of thickening will cause leaflet restriction. And what I pointed out earlier, again, the beam hardening or streak artifacts, they go in a different direction. That's, again, important when differentiating the true finding of thickening or an artifact, which is, for example, illustrated here. You see that area of hypoattenuation. It doesn't really follow the attachment side of the leaflet. It also does not have the curvilinear pattern of the leaflet. So in this case, I would refer to that as a beam hardening or streak artifact. Again, you're looking for this meniscal-shaped configuration. And it's important to then actually employ appropriate grading scale. And when we put together the guidelines which were published earlier this year, we came up with a quantification method which is very similar to coronary artery stenosis grading, a semi-quantitative 4-tier grading scale in pretty much 25% brackets, less than 25, 25 to 50, 50, 75, and then above 75. Important is to apply this to the center of the leaflet. Often, if there's thickening, it is really symmetric with the, usually starting from the very base. You won't find thickening more pronounced on one side or the other. That's highly unusual. For that reason, keep in mind how you align the MPR and that you're really focusing in a perpendicular fashion at the center of the leaflet. So in this case here, obviously it's only the base. I would refer to that as less than 25% of thickening. Another reader may perhaps interpret that as 25 to 50, but nobody is going to call this more than 75% leaflet involvement. So in terms of leaflet restriction, that's a very difficult topic. We have been asked by multiple vendors when we did the core-lab reads to also grade restriction. I would never, ever mention the word leaflet restriction in a report if there's not concomitant thickening, simply because CT lacks the appropriate temporal resolution. And here's a case of a surgical bioprosthesis. In late systole, you see that 2 leaflets are still open, 1 is already closing, and that's a very common phenomenon, that there's an asynchronous motion. In mid-systole, all 3 leaflets are fully open. So if I had only 1 frame, I may misinterpret that as leaflet restriction. I think that would be then an overcall or an incorrect diagnosis, so I would stay away from that. If you have a finding of leaflet thickening, then I think it's correct to also grade the degree of restriction, but not without thickening. Other reasons for abnormal findings, there are plenty. One is pannus. Pannus is usually distributed in a very circumferential fashion, and most importantly, it extends somewhat from the LVOT to the inflow of the leaflet. So it's actually pretty easy to differentiate pannus from leaflet thickening on CT. Here an even more pronounced finding. And those patients may actually also show up with an increased gradient, and that's, I think, one of the benefits of CT to really differentiate those different scenarios. Then, of course, structural valve degeneration as shown here in a core valve case with calcification. And I think the other differential is patient-prosthesis mismatch. Here, patient with valve-in-valve procedure. Again, not the greatest images, very poor contrast attenuation, a lot of beam hardening and streak artifacts, but you can appreciate that there's one dark line crossing those artifacts, and there's a correlating finding here on the on-fast view. This patient actually had an increased gradient after valve-in-valve, both on the post-discharge CT and then even more increased on a 30-day follow-up. The 30-day follow-up most likely related due to the new finding of leaflet thickening. The patient then subsequently was anticoagulated. We performed a follow-up CT scan. The thickening was gone. Patient still had an increased gradient because due to the under-expansion of the sapien valve, and then subsequently underwent valve fracturing to pretty much enhance the expansion. For that reason, I think CT is a very, very good diagnostic tool to separate those different entities in patients with an increased gradient after TAVR. So and then, of course, a word of caution, not everything what is hypoattenuated on a post-TAVR CT scan is thrombus. In this case, a very heterogeneous configuration of hypoattenuation, pedunculated, somewhat extending in towards the inflow. That's a case of endocarditis. It's very, very rare, but I think that's something you should keep in mind to not automatically call everything what is hypoattenuated on those scans as leaflet thrombosis. So in summary, I think CT is a very useful diagnostic modality in patients with suspected peripatetic valve thrombosis. It really helps to identify of how many leaflets are involved, what is the severity, and of course the differential diagnosis. It's important to employ a dedicated acquisition protocol. I would cover the entire cardiac cycle, and I think most importantly, perform heart rate control, especially if you're using a single source system. And then, of course, be aware of the normal and abnormal appearances of different valve types. Thank you very much for your attention.
Thank you very much. Our next speaker actually will present a case. Dr. Weir McCall on CT pre-TAVR saves the day. Yeah, saves the day. I'd like to see this.
Well, thank you for the introduction, and thank you for the course organizers for inviting me. I slightly thank them less for giving me this title of CT pre-TAVR saves the day. It's maybe because I'm a CT enthusiast, but partly I think every day we perform a CT, we're saving the day. We're picking up people at risk of rupture, embolization, and vascular access disasters. And because of that, the three things that we're seeing up on the screen of an annular rupture, embolized device, and a completely avulsed iliofemoral artery are no longer commonplace. And in fact, in the most recent low-risk trials, partly due to the work of the core lab from Jonathan and Philip, we've now seen an event rate of about 1 in 500 for coronary occlusion or rupture, compared to 1% back in the earlier days of TAVI. So what can I bring to you today to discuss and present off a case where CT is perhaps saving a day in a novel or slightly different pattern? And whenever I was racking my brains, as is usual the way, I turned up at the MDT for the structural team. And two cases occupied almost the entirety of the 3-hour meetings, with arguments going backwards and forwards. And I thought, well, these might be a good way to start that discussion, along with one other that married up very well with them. So the first is a case of a 78-year-old female presenting with 9 months of progressive shortness of breath on exertion, NYHA 2 to 3, with angina once to twice per week. She had chronic kidney disease, was under workup for chronic anemia, and was also hypothyroid, with markedly raised gradients on a small aortic valve area. So the CT shows a lovely annulus conducive to TAVR. There's no adverse root features. There's no bicuspidity. The right coronary heights are good. Both coronary heights are good, and the sinus is also good. Iliofemoral access was good with only mild calcification and tortuosity, but good diameters bilaterally. So all in all, an excellent candidate for iliofemoral TAVI. So green light from CT. Apart from this 7 centimeter long segment of colonic thickening at that right hepatic flexure, all entirely consistent with a colonic cancer. So CT saves the day? Maybe, we'll come back to that. The second case, an 84-year-old male, 3 months of progressive shortness of breath on exertion, NYHA3, he's a smoker, type 2 diabetic, hypertensive, has had a previous TIA, all consistent with a high-risk candidate with elevated gradients and small aortic valve area. Once again, CTA shows an excellent annulus with no adverse root features, good coronary heights and good root dimensions, as well as good vascular access bilaterally. While there was moderate calcification, there was nothing more than 180 degrees. So again, green light for a TAVI, except on the rest of the scan, this is what's there, and I don't need an arrow in this one to point out the large mass originating in that right lung. Now, this patient was rapidly triaged on for PET, which showed that this was a localized malignant tumor within the lung with no nodal and no distal metastasis, completely unknown off to this point. So once again, CTA saves the day, or has it? We'll come back to that. Final case, 64-year-old female, 2 years of progressive shortness of breath on exertion with 2 syncopal episodes, the most recent of which has landed her in hospital, and workup for these episodes. She's had a previous PE in the distant past, cholecystectomy, bilateral total hip replacements, markedly raised gradients again, but also an elevated right ventricular systolic pressure. And we know pulmonary hypertension is an adverse marker of risk in the TAVR cohort, although will frequently fall with insertion of the valve. Once again, CT shows a suitable annulus with no adverse root features, but does pick up a BAF. So, has the CT finally saved the day? Well, no, it was known on the echo. We've added nothing yet with this. The coronary heights are good, the root is good, and the iliofemoral are good with adequate access bilaterally. So once again, a green light for TAVR. Except once again, there's yet another finding on the CT. The pulmonary artery is absolutely enormous, measuring 6 centimeters across. And while you can get a bit of pulmonary hypertension with aortic stenosis, you don't typically hit 6 centimeters in transverse diameter. This is far more consistent with a pre-capillary pulmonary hypertension. And indeed, this patient was sent on to the cath lab and onto the SPECT VQ, which showed multiple perfusion defects with no matched ventilatory defect. So this is a case of chronic thromboembolic pulmonary hypertension, although with the normal CT before this, we know that there's no central operable disease. This is a peripheral variant of chronic thromboembolic pulmonary hypertension. So 3 cases, 3 incidental findings, 1 colon cancer, 1 lung cancer, and 1 chronic thromboembolic pulmonary hypertension. So CT pre-TAVR saves the day, or does it? What does the room think? No. Shoot from the hip, TAVR first, ask questions later. Or yes, we've picked up some life and treatment altering diagnoses. Show of hands for no, TAVR first, ask questions later. No one's wanting that. Oh, interesting. Hands up for yes, life and treatment altering diagnosis detected. Excellent. Yes, potentially it has. Now, I don't know how many of you are familiar with card sharks or Bruce Forsyth's Get Your Cards Right. We're going to play a game of higher or lower. So symptomatic severe aortic stenosis, I've chosen the 5 of hearts appropriately enough because it's the heart, and also 5 because there's a 50% 1-year survival from untreated symptomatic aortic stenosis. So, yeas in the crowd for whether colon cancer is going to have a higher 1-year survival than severe AS. Excellent. Yeas in the crowd for lower 1-year survival. The crowd has spoken and they're quite correct. The king of clubs, this is an excellent diagnosis to receive, while it might not seem like that for the patient. But even untreated, you're talking about a greater than 90% 1-year survival with low-stage, non-metastatic colon cancer. So now, comparing back to symptomatic severe AS, how about our stage 1 lung cancer? Yeas in the crowd for higher survival. Again, all the hands up. Yeas in the crowd for lower survival. And the crowd is again correct. 6 of diamonds, so there's a 58% 1-year survival for untreated stage 1 lung cancer. And finally, how about our inoperable CTEF? Yeas in the crowd for better survival than severe AS. It's a bit more uncertainty. A couple of hands, but not the same overwhelming wave that we saw for the first two. Yeas in the crowd for lower survival than severe AS. Oh, and this degree of contention. But in fact, with optimal medical therapy, there is a 73% 1-year survival, even in inoperable CTEF. So we've got 3 diagnoses picked up by CT, all with better survival than leaving that severe AS untreated. And incidental findings are common on pre-TAVR CTA, found in about 20% of cases in multiple series that have been published now. And they are associated with poorer survival, as you might expect. But in fact, in a very nice paper published in the European Heart Journal of Cardiovascular Imaging, they showed that whenever these findings were tackled and appropriate patients were selected, that these differences between these two groups completely disappeared. So what happened in these 3 cases after huge amounts of arguments and discussions in our MDTs? Well, the first patient got a TAVR and then went on to get their curative colonic resection. The second patient got their TAVR and went on to get stereotactic ablative radiotherapy because their risk was still too high for them to go for a curative surgical approach, hence why they were being considered for the TAVR in the first place. And in the CTEF, well, they were actually sent on for optimal medical therapy, and following that, their symptoms markedly improved. However, whenever we consider their bicuspid valve, and I didn't highlight it earlier, their ascending aorta was slightly dilated at 45 millimeters. And whether it was due to the increased cardiac index following resolution of the pulmonary pressures with an increased throughput, over the subsequent year of follow-up, their ascending aorta underwent rapid growth. But because their pre-surgical risk had come down in that intervening period due to their optimal medical therapy for their CTEF, they were now able to qualify for a surgical aortic valve replacement and root replacement at the same time. So these incidental findings are appropriate, and you might not save the day. They may still go for their TAVR, but you may save the year. You may allow them to have a curative approach in the downstream management following their TAVR. And every so often you will pick up something that actually explains their symptoms better than their severe aortic stenosis, or give you something to optimize the patient prior to operation or intervention. And with that, I thank you all for your time.
Thank you so much. That was entertaining as always, and also very interesting way to look at things. I'm going to welcome Dr. Mamarian to the podium. He comes to us from Houston, from Methodist, and he'll share his presentation now.
Okay, so I was asked to talk about a case where we use CT, where maybe we didn't use CT, and could we have prevented this complication? And this was a little bit of a difficult talk to give, because honestly, we do CTs on everybody before they go for TAVRs. So I was kind of a little bit hard pressed to find a case that would kind of fit this description, but I'm going to give it my best shot here. So let's talk about this case. 82-year-old man, prior history of hypertension, hyperlipidemia, and coronary disease, referred for TAVR evaluation, functional class 3, heart failure symptoms. Prior stenting of the right and circumflex coronary arteries at various times, 2000, 2006, but recent invasive coronary angiography showing patent stents, no obstructive lesions. And he also had a little caveat of a prior limited dissection of the infrarenal aorta. We had an endostent placed in 2017, which was successful. Current medications, Plavix, aspirin, Crestor. Blood pressure on initial visit, reasonable 158, heart rate 61. Physical exam was normal except for typical systolic ejection murmur, right upper sternal border, radiation to the carotids, delayed carotid upstrokes, consistent with his aortic valve disease. ECG, sinus bradycardia, normal conduction, normal PR interval, old inferior wall MI, and inferior Q waves. Renal function was normal, lipids, LDL was 62, not unreasonable. This is what his echo showed, pre-TAVR echocardiogram, LVEF 65 to 69%, normal LV cavity size, concentric LVH, again not too surprising, RV function normal, severe AS with a mean gradient of 44 millimeters of mercury, peak velocity across the valve, 4.3 meters per second, aortic valve area, 0.6 centimeters squared, PA systolic pressure is elevated, and the patient had mild AI and mild MR. So the patient went for a CT as part of the pre-TAVR evaluation, and I think you can see the valve in motion, systole and diastole. That's pretty severe AS. And you'll also notice that the patient also has some degree of aortic insufficiency. The calcium score on this aortic valve was 3920, severe. And the patient did have an aortic valve area of 0.65 by CT, very consistent with the 0.6 that was gotten by echo. And there was mild aortic regurgitation with an anatomic regurgitant orifice area of 0.08. which is very consistent with what was seen on echocardiography. Patient, this is the typical view in terms of the annulus and the aorta. Of course, he had annular measurements in systole. The perimeter was 89 millimeters. The area was 595 millimeters squared, fairly large annulus. And this is a dynamic look at this patient. And you'll notice the mitral valve looks normal. There's really no significant mitral regurgitation. There is significant MAC. And I hope you all recognize that there's also significant subvalvular calcification that extends really all the way down into the LVOT and even affects the anterior leaflet of the mitral valve and very, very dense. So you can see that better here. In this particular view, all of this in terms of calcified valve and extensive subvalvular calcification. And this was along the non-coronary cusp and again involved the anterior leaflet of the mitral valve as well. Now, Jonathan is very familiar with this paper in terms of looking at what the impact of calcium in the aortic root does, and in terms of this is balloon expandable valves, not self-expanding valves. But what was shown in this study, obviously, is that upper LVOT calcium increases your risk dramatically in terms of having aortic root rupture, and also the fact that if it's involving the non-coronary cusp, and these were just some examples in terms of calcification in all of these different cases that had rupture, and you can see in this case, after the TAVR valve was placed, there is rupture of the anterior sinus where there was calcium in the non-coronary sinus, involving the non-coronary sinus. And in this study, what was shown that calcium in the non-coronary cusp and prosthesis oversizing were the greatest predictors of rupture. So this patient, I guess you would be considered at high risk based on his calcium and the fact that it extends way down into the LVOT. This patient did receive a 34 millimeter core valve during rapid pacing, which would actually be the proper sizing based on the recommendations. Remember, the annulus perimeter was 89, and so this would be a reasonable valve to put in terms of in terms of this particular individual. And we know that really CT has become the standard by which we determine what sizing should be done. There are many studies out there showing benefits of CT over both TE and transthoracic echo. And this particular study by Binder, again, showing how using at least the sapien valves that you can identify what size to use based on what you see in terms of the area of the valve. And in this particular study, looking at paravalvular regurgitation with a secondary endpoint of in-hospital death, aortic annular rupture, or severe PAR, that CT did much better than echocardiography. So we're well aware of these particular situations. So this patient then went to the cath lab to have the valve implanted. And I think you can see the valve there. And following valve expansion, the patient became extremely hypotensive, had equalization of arterial and LV diastolic pressures. He had to receive norepinephrine to maintain his blood pressure above 90 millimeters of mercury. I think you can appreciate where the valve is. The valve is actually sitting rather high up as compared to where it would normally be. And if you look at the images here, you can see that there actually is severe regurgitation, paravalvular regurgitation. And at that time, an echocardiogram was also done, and you can see that there's severe eccentric aortic regurgitation. And this is actually the mitral valve leaflet, and that's that calcium on the leaflet. You can see that very nicely. And so in any event, this was severe paravalvular regurgitation. So what was done in this case? The valve was dilated with first a 25, then a 26, and finally a 28 millimeter balloon. There was minimal effect on the PVL, and a second core valve was deployed, but this time 3 millimeters below the first one, with the diastolic blood pressure immediately increasing to 60 millimeters of mercury. So in that regard, the paravalvular leak was successfully taken care of with the use of deployment of a second valve. Now, what could we have done maybe, or what could we have done in the cath lab, obviously, to maybe improve this scenario? Well, I'm going to show you another case, and this is something that we gained maybe from our other interventionalist colleagues. This is a congenital case, and this was a patient who had a CT of the chest, and the patient actually had a severe coarctation, and they also had a pseudoaneurysm. This was a hemishield graft that had degenerated, and this was how the graft should have looked, and that's how it, but obviously there was degeneration. So what was done here is actually co-registration of the CT in the cath lab to help guide that guiding catheter through that small coarctation to help deploy the endograft, okay? And again, you can see in this particular circumstance, this is after the fully deployed, the fully deployed graft. In terms of positioning to make sure that everything looked well. So maybe in this particular case, if we had actually done more of a co-registration in the cath lab, we might have been able to actually better position the valve, because that calcium obviously made a big impact in terms of positioning that valve, and we might have been able to do a better job in terms of using co-registration to help properly put the valve in the right place to begin with, instead of dealing with the complication of hypotension and shock. And there actually are some now papers that have been published. This was back in 2016, and this is now just one that came out just recently, this past several months ago in the Journal of Cardiovascular Tomography, looking at 3D printing as a way to possibly identify what the best sizing in certain individuals who might be at risk, who have certain anatomy, either a lot of calcium on the valves themselves or in the LVOT, where we might be able to use this to help guide us in terms of planning our TAVR procedures. Not for everyone, but certainly in more high-risk individuals, this might be a reasonable alternative. Incidentally, this patient also, this was his pre-TAVR ECG. And you'll see he has sinus rhythm, and he also has normal conduction. And this was his post TAVR ECG. And now you can see he has marked first-degree AV block and left bundle. And this was probably, although we don't understand all of the different things, I mean, it depends on how far down you go into the LVT and all this, but I mean, he had multiple dilations, which certainly was not an advantage to his conduction system, which probably led to this. And he needed he had a pacemaker implanted prophylactically 5 days later, and has done well since that time despite these procedural complications. So this is just an example of where not only might we use TAVR, CT and TAVR as a pre-test procedure to actually look at this, but maybe also be able to merge those images in the cath lab or do maybe 3D printing to better identify who might benefit and thereby potentially avoid procedural complications. Thank you very much.
Thank you for the excellent overview. I think highlighting the conduction disturbance issue is another example of the role of TAVR, understanding patient-specific anatomy. Beautiful paper from Ashraf Hamdan, published a couple of years ago in JACC Intervention, looking at the membranous septal length to understand personalized risk of compression of the bundle of His and therefore new onset conduction disturbance. So I'll open it to the floor. Certainly our speakers are here. If there are any questions or comments, or if people can even suggest some of the outstanding challenges that they feel are remaining for the field of CT for TAVR. Please, if you could use, Dr. Hurwitz.
I have a question for the panel and the audience. Does anyone have any experience in a patient who's severely allergic to iodinated contrast for TAVR planning using MR or gadolinium CT?
Well, I mean, there's certainly, I don't know if Gianluca is here, but certainly the Monzino group has published using MR, and also Gregor Pacha and his colleagues from Bad Kreuznach. Come up, Philip, if you wish to answer too, about the role of MR.
Yeah. Can you make any comments about how you adjust for measurements?
So there's one paper, I think, in the European Heart Journal of Cardiovascular Interventions by Philipp Rühle, and at that time we compared a respiratory ECG-gated non-contrast MRA versus CT. I think what you have to keep in mind, first of all, is that those respiratory-gated acquisitions, it's a true volume. It's somewhat temporal average, but most often diastolic. I don't know, it depends on, I think, your equipment and whether you have a more advanced sequence that you could push it into systole, but most often it's diastolic. So especially when using a balloon expandable device, you have to account for that, because those sizing charts, they are all based on systolic dimensions. If you're using a self-expandable device, it's, I think, less important, because those are more forgiving in terms of the degree of oversizing. For that reason, in that paper, we applied a corrective factor to account for those dynamic changes which you would miss. Then, of course, the pattern of calcification, you can get an idea on MRI, but I think it's not as accurate. So I would actually then do a combination of a non-contrast enhanced ECG-gated CT plus the MRI. You know,
if I could, and I know, Mona, you're waiting for a comment, but I know Joao and I'm sure John. I don't know, John, if you were going to comment, because such expertise also in MR and what you're doing at Minneapolis Heart. I don't know. Sorry, Mona. It's John. Do you want to? Were you or the two J's? I don't know.
Yeah, the John and John,
age before wisdom now. Joao will go first, and then.
No, I think we have had some experience doing this back in Cleveland and Pittsburgh, just with selected cases. So, as Philip mentioned, a non-con gated CT, and co-register that with a 3D whole heart acquisition. There is a recent paper, a small cohort of patients, a group from Penn, trying to do in systolic phase. Acquisition is obviously longer, but they were able to get reproducible measurements too. So.
John, did you have anything to add to that before Mona? Okay, all right.
So I'll go first. Right, so one interesting situation we had was where during a TAVR, the TAVR was all, the assessment of the TAVR on CT was fine, except that the patient had a pheochromocytoma. So that would not have been longevity of, living post-TAVR or pre-TAVR. It was actually going to impact the procedure itself if the patient was true pheochromocytoma. The other thing I have is we have in India a lot of people who have vegetations pre-TAVR on the aortic valve. So is everybody actually putting filters into the carotids? In this patient, we put filters into the carotids, but the patient actually ended up embolizing into the iliac vessels. It's like an interesting situation we face.
Yeah, maybe we could ask Professor Waxman, Ron. I don't know. I mean, there's obviously small randomized trials led by Sushil Kodali and some others on the role of protection device. In standard of practice, do you using protection device, or how do you determine? I mean, the stroke rates are so low.
So the stroke rates in low risk are extremely low, and the data to use protection devices as a whole is failed in the randomized clinical trial to show clinical or even by MRI perfusion defects. But if you gather a series of studies and you try to do meta-analysis, you may see some direction that it is protective. There is no doubt it does collect debris, but I think the brain is much more forgiving. So some centers using it in 70% of the cases. In our center, we're using maybe in 3% of the cases. When do we use it? Like yesterday, we used it because the patient already had a stroke and she had a mobile thing on the arch. So we would use it, but is it really helpful? We really need a large randomized trial to support routine use of that. The trials, the randomized trials, also in the surgical arena, failed to show efficacy. So it is cost $3,000. This is usually the margin that we make on the TAVR. So it's kind of hard to use it excessively on everyone unless it's marketed. I'm going to prevent you the stroke. I'm going to show you what I collected in the basket.
That's well said. John, Dr. Lesser.
I have a question for Philip about his semi-quantitative HALT.
Sure.
And do you have any information or future plans of using that to try to make more sense about future treatment, about the gradations of HALT?
Yeah, I mean, we'll let Philip, I mean, obviously those data will come at TCT from the low-risk cohorts. Well, I don't know if they will. We'll assume they will, and maybe from one of the other low-risk cohorts, maybe at CRT. But I think we need to understand better. What I think why it was defined and so important is that it also allows an ordinal scale, a 12-point scale potentially to understand, not just binary yes, no. There's clearly patients with a little bit of thickening, and then there's patients with a lot of thickening. And you don't need to be a rocket scientist to know that there's probably a difference in the two. But
we actually presented in the low-risk TAVR that we did about 15% at the balloon expendable and 0 in the self-expendable. But this is a small cohort mainly for the balloon expendable. So if I have to make a prediction, you are going to see it in the balloon expendable more than the self-expansion. What to do with that? I don't know. I mean, when we look at the 30 days, it looks much more pronounced than at the 1 year. And we saw actually less at 1 year because our patients are being continued to followed. With terms of impact on gradient or impact on clinical events, there was none. So it is something that is not pleasant to see. You see it more probably in the balloon expendable than the self-expansion, but I don't see any clinical implication of that so far.
I think that's well said.
I have one, on that case that you showed, I thought that I saw something which we see in folding in self-expansion, and that's a phenomenon that you have to be aware to, especially in a very calcified. You may see some sort of infolding, and there is a string sign, and I thought that I saw it on the side. So if that's the case, and you do post-balloon, it doesn't help, you probably have to put another valve in a valve to overcome this.
Yeah, and that's exactly what happened because balloon expansion didn't do anything, and that's why a second valve was deployed. Yeah.
Well, I see that everyone's getting organized. There are, I believe, 3 satellite symposia now at noon. I want to thank everyone for attending. I want to thank the speakers, especially Dr. Waxman, to join us as an interventionalist and provide his perspective. And I'm really excited as a field. There's a lot of outstanding challenges, and I look forward to hopefully collectively answering those in the future. So thank you again. Thank you.